Dr. David Bangsberg. He's a native of Portland, Oregon, and the founding dean of the OHSU PSU School of Public Health. He's a former professor at Harvard Medical School, Harvard School of Public Health, and Umbarara University of Science and Technology in Uganda. Dr. Bangsberg received the Clifford Barger Mentoring Award, given to 5 of 12,000 Harvard faculty. He's an expert on HIV treatment and prevention in the U.S. urban poor and in rural Africa. President Bill Clinton described his work as the nail in the coffin on the debate as to whether poor people in Africa could succeed on HIV treatment. His goal as dean of the OHSU PSU School of Public Health is to grow the health workforce, advance knowledge, and implement policies to improve the health and well-being of Oregon and beyond. Dr. David Bangsberg.
Thank you, it's great to be here. I took a Twitter photo over there of everyone dancing. If any of you don't want to be on my Twitter feed, come up to me privately and I'll take another one in the next session. "2016 was the first time in U.S. history that life expectancy declined not 1, but 2 years in a row. This is in part due to the opioid epidemic, the over-marketing, over-prescription of opioid medications, and also the root causes of addiction, depression, anxiety, economic loss, despair, racism, and other forms of oppression. This is occurring in a context where we have the most expensive healthcare system in the world, and we have the worst outcomes of any industrialized democracy. Let me say that again. The most expensive system and the worst outcomes. U.S. healthcare is in a crisis. But we have seen crisis before. The last time U.S. life expectancy declined was in 1993, at the peak of the HIV/AIDS epidemic. That epidemic was also affected populations that were marginalized and stigmatized. And our initial response to that epidemic was one of fear and denial. But public health practitioners, scientists, community mobilizers, educators, and advocates came together to turn that epidemic around. And HIV is no longer killing young people like it used to. And while important work remains to be done in the HIV/AIDS epidemic, conquering that epidemic is within reach. We need to find our way out of this crisis. And the solution is in this room, where we bring together public health practitioners, scientists, educators, advocates, community mobilizers in the same way that we address the HIV epidemic. What I'd like to do today is tell a few personal stories of how I came to believe that public health, including the social determinants of health, really matter. And why I believe that careful scientific observation linked with evidence-based advocacy can bring us out of this crisis. As was mentioned, I grew up in Portland, and I left when I was 18. I went to college, and I came back every summer to work at the OHSU in a neuroscience lab. My dream was to become a brain surgeon even cure a brain disease. I studied hard in college, and man, I secured one of 5 full MD PhD scholarships at Johns Hopkins Medical School. I thought I was all set. Little did I know that East Baltimore would change all that. In 1985, I showed up at Johns Hopkins Medical School in my 1979 Toyota Celica. My first stop was a medical school housing office. I went in the housing office, there was a bulletin board. I wrote down some names, numbers of people looking for tenants, made some phone calls, and scheduled appointments. I walked back out to my car. Where are my keys? They're in the ignition. Oh my gosh. There was a man on the street corner. He saw my predicament. He said, "Hey, I think I can help." He went to reach in his backpack, pulled out a Slim Jim, and the door was open. I said, "Wow, you just saved my bacon. Thank you so much." He said, "No problem at all. You seem like a nice guy. How'd you like to come over to my place and smoke some crack?" I said, "That's really kind of you. Thank you. But I got to meet my landlord. I don't want to be late. I'll be around for a while, but maybe next time." I studied hard in medical school, and then I remember my very first patient. His name was Anthony. Anthony was a tall African-American injection drug user with endocarditis. Endocarditis is a disease that infects the heart valves, often caused by injection drug use. The doctors on the medical team call patients like that a dirtball. My job as a third-year medical student was to ask Anthony how he was feeling, record his vital signs, and examine him. I am deeply embarrassed to say that I was scared to walk into Anthony's room that first time. But I walked in with my short white coat, and Anthony said, "Good morning, Doc." I said, "Well, I'm not really a doctor. I'm just a third-year medical student." And Anthony greeted me with appreciation, intelligence, and I would soon find a wicked sense of humor. It was the favorite part of my day. But I was confused. This is what my doctors, teaching doctors, were calling a dirtball. So I went up to my chief medical resident and I said, "Could I please follow every injection drug user who comes in with endocarditis?" He looked at me kind of perplexed, and he said, "Sure, I guess so. No one else wants to." And so I did. Over that month, followed about 15 patients. And none of them were exactly like Anthony, but all of them had rich and compelling and often tragic stories. It was that month that I realized that I was a racist. This is a topic that I need to approach with humility as a white man of privilege, recognizing that millions of people have suffered from and fought against racism for centuries. And I was very slow to begin to learn. I'm still learning the impact of racism. But I had no idea that I was a racist growing up in the West Hills of Portland, Oregon, where I thought that everyone could dream of becoming a brain surgeon, even curing a brain disease. But I learned that I had that dream, and the possibility of achieving that dream, because I grew up in the West Hills of Portland and not East Baltimore. And I would then learn that where you're born not only determines your schooling and your opportunity, but determines your health, your family's health, your children's health, and your entire community's health. And the difference between a good zip code and a bad zip code is 25 years of life. And that's not right. And that's why public health matters. The other thing happening in Baltimore at the time was there was this new disease called HIV/AIDS. We didn't know much about how HIV made you sick at the time. We just knew that once you had a diagnosis, you had about 6 months to live. I'm going to just move them to the second black slide. Yeah, thank you. I started testing gay men, injection drug users, and their female partners in a free gay men's clinic. I tested 9 people HIV negative until I met Paul. Paul was a young gay man who came in because his friends talked him into getting tested because he wasn't feeling well. He had a bad cough that wasn't going away. I awkwardly tried to joke with Paul, it's going to be okay, everyone I test is HIV negative. Sat him down, explained what the test was, drew his blood, gave him his number for him to come back for the results a week later. Paul came back a week later, sat down, he gave me his number, looked at his number, opened up the book. There it was. HIV positive. Look at that again. HIV positive. I tried to explain what that meant, but I don't think he heard a single word. We brought him to Hopkins Hospital, where he was admitted. And I went to visit him every day for the next 3 weeks until he died of pneumocystis pneumonia. All of a sudden, being a brain surgeon, or even curing a brain disease, didn't seem that important to me. I dropped out of my PhD program, gave up my scholarship to care for the Pauls and Anthonys of the world. The next stop was medical residency at Columbia Presbyterian Hospital in North Harlem. At that time, a young African-American male born in Harlem was as unlikely to live as long as the same male child born in Bangladesh, despite all the resources we had. And that wasn't right, and that's why public health matters. Then went to San Francisco General Hospital, the Mecca, to learn how to study and treat HIV. Not long after arriving in San Francisco, new medications were discovered that turned HIV from a death sentence to a manageable chronic disease. But not everybody received such treatment. Some thought that if you give these miracle medications to the homeless, the mentally ill, to drug users, often people with dark skin, that they would miss their doses. The virus would continue to replicate, become resistant to these medications, and then these highly drug-resistant viruses would spread through a larger population. And as this New York Times article says, doctors withhold pill regimen from some. Failure to follow a rigid schedule could hurt others they fear. So we set up a program to learn how to treat the homeless, the mentally ill, and drug users. I remember one day I was on daddy duty and I was with my daughter, 5-year-old daughter, Brooklyn. We're in the clinic, and I just finished interviewing a woman named Lori, who was an injection drug user and also a sex worker. I remember the scars on her arms and even the scars in her neck because she had used all the veins in her arms and had to inject in her neck. I left the interview, I was reviewing my paperwork to make sure it was complete, and I turned around and there was my 5-year-old daughter sitting on her lap. Lori was admiring a bracelet that my daughter had made in kindergarten. And not just admiring the bracelet, she was asking her about every bead. I like that blue one, that's pretty. But the pink one, that's my favorite. What's your favorite? My daughter was beaming, finally, someone appreciates me in the way that I deserve. So at that moment, I realized I had misjudged Lori in the same way that I had misjudged Anthony. This was not a node of transmission of the HIV epidemic in San Francisco. This was a mom who loved and terribly missed her 3 children that had been taken away by Child Protective Services. Our program progressed, and eventually, using case management, linking people to housing, to drug treatment, to mental health treatment, along with the simplification of HIV treatment that was easier to take, we brought successful HIV treatment rates from 9% up to 90% in this population. Then a student came up to me and said, the stuff you're doing on HIV and poverty, that's great. The real questions are in Africa. That's where 90% of the epidemic is. I think we should go take that on too. So we went to a small town in southwest Uganda called Mbarara. It was a medical school that had an HIV clinic with 5,000 HIV positive people, and not a single person was on treatment. Even though prices have gone down so much of HIV drugs that HIV treatment was economically viable, even in the most rural parts of Africa. I said, this isn't right. So we started raising money in $5, $10, $20 donations, and thought if we could raise enough money that we could put 1 person on treatment, we should. So we did. I went to the clinic director. I said, we can treat 1 person for 5 years. Who should we treat? The clinic formed a committee of the doctors, the nurses, the community. They debated and discussed. And they picked this man, Elijah Muzunguzi. They picked Elijah because Elijah led a song and a dance troupe that would educate villages about HIV prevention. They would go into the village and sing a story about a woman who found out that she was HIV positive after going to prenatal clinic, and then going home and telling her husband, and her husband beating her. Then they would sing to the village, where did this woman get HIV? From her husband. Why would her husband first give her HIV and then beat her for it? The clinic said, if we can help Elijah, Elijah will help others. So we put him on treatment. He was nearly dead with tuberculosis meningitis, and he slowly and then more rapidly began to recover. And then he led our HIV treatment program that put 2,000 people on treatment. And not only that, he started to teach these families how to build chicken coops and start a chicken coop business to raise families out of poverty. The clinic was right. If we helped Elijah, Elijah would help others. We started to put more people on treatment, and they started to do just as well as Elijah. We were amazed. We measured how well they took their medications, and wow, this is something else. We published our first few dozen patients in a journal. And then on Friday on 2003, before Labor Day, I got a phone call from a man named Donald McNeil. He was a reporter for the New York Times. He said, I read your paper. Do you think it's true? I said, yeah. He said, why? And I explained why, about levels of social support to help people overcome, to take their medications against amazing economic and structural barriers. And then on Monday, Labor Day, I heard the thump on our front doorstep, and there was the New York Times. Front page, left-hand side, below the fold. Africans outdo U.S. patients in following AIDS therapy. And now 19 million people are living with HIV around the world with normal life expectancies. If we can tackle HIV/AIDS, we can tackle problems here at home. We can prevent depression in 1/3 of Oregon women. We can prevent the epidemic of suicides Suicides often in middle-aged white men who have economic loss, a sense of despair, and take their lives with a gun. We can turn around the growth of underactivity and overnutrition, leading to obesity, cardiovascular disease, and cancer. And I believe that we can even end homelessness with the same type of community mobilization and call to action that we used with the HIV epidemic. But where do we start? Well, first, we start with the science. And we are in an amazing position in terms of where we are in understanding how the social determinants of health impact lifelong health outcomes. It all begins with the fight and flight response. You're familiar with this, that the fight and flight response is highly adaptive when you're on the savannah looking eye to eye with a lion. Get your blood pressure up, your heart rate up, your muscles start to release glucose to be ready to move, you become hypervigilant, and you're ready to fight or run away. But when those levels of stress continue, and the levels of what's called toxic stress, those chronic changes become permanent. Your metabolism is changed. Your neurochemistry is changed. It even rewires your brain. Even your genes are changed, such that you can pass those ill health effects from mother to child across generations. These toxic stress is most severe in early childhood, called adverse childhood experiences, which could be early sexual abuse, could be violence, could be sudden loss of a parent or incarceration of a parent, or it could be simply living in a dangerous neighborhood or not knowing whether you will have food on the table. Some of you may have high cholesterol and may take a statin. If you take a statin, that reduces your risk of a heart attack by 25%, and that's considered an amazing, a very large effect. Severe adverse childhood experiences don't increase your risk by 25%. They increase your risk of heart disease by 200%. They increase your risk of emphysema by 400%. They increase your risk of alcoholism by 700%. And they increase your lifetime risk of suicide by 3,000%. We aren't going to be able to treat our way out of this. We have to engage in communities to prevent these events from occurring, and when they occur, to mitigate those effects. We need a new type of public health practitioner. A public health practitioner who is from the communities with the greatest health disparities, who understands the causes of adverse childhood experiences, has the trust of communities to design and implement interventions to prevent and mitigate their effects. We are proud at the OHSU PSU School of Public Health to launch our first philanthropic initiative where we raised $2 million for scholarships for students who are first-generation college students or from other marginalized communities to begin to build this new public health workforce. We also need a new type of clinician. A clinician not only understands how to diagnose and treat disease, but understands the upstream social determinants of health, the system-level responses so we can make a population difference before disease occurs. We need pediatricians who can screen, identify families at risk, and refer them to counseling support to reduce the risk of toxic stress. We need dentists that understand the social, economic, and structural causes of chronic untreated dental pain in children, which is the #1 cause of poor academic performance. We need pharmacists who not only understand effective pharmacotherapy, but understand how we can constrain and control drug prices, which is the major driver of explosive healthcare costs. And we need nurses who are not only skilled in the clinic and in the hospital, but skilled in the community to build social support and leverage these community interventions. We also need a new type of science, a science that leverages big data and novel analytics, because we have more data on what we eat, drink, smoke, what we buy, how we exercise or don't than ever before. We can take this big data with machine learning, integrate it into an electronic health record so we can intervene on behaviors before they make us sick. And we need to identify improvements in health systems to make them more efficient, more effective at the population level. Oregon is a great place to do this. Oregon has always been a leader in health policy innovation. With the Oregon Health Plan, we have a strategic and rational approach to prioritize cost-effective care. With the Medicaid waiver and the CCOs, the coordinated care organizations, we are now incentivizing payers and providers not only to treat disease, but to promote health. The CCOs have been effective at reducing unnecessary hospitalizations, reducing ER visits, and constraining the cost escalation of healthcare costs to a modest 3.5% per year. I'm really excited for the Oregon Health Authority in partnership with the Oregon Health Policy Board to design CCO 2.0 so we can move even further upstream and create new value to healthcare at the population level. And this isn't just for Medicaid. Medicare is going to go in this direction, as will private payers. Private payers are estimated will invest 30% per year in what's called population health management. Google, IBM, GE, Apple are all making major investments. In fact, just in the New York Times, it's announced that Berkshire Hathaway, Amazon, and JP Morgan are all investing in a population health management system. And I know nobody who knows how to predict the future better than Warren Buffett. And Warren Buffett says, "The ballooning cost of healthcare is a tapeworm on the American economy. Our group does not come to the problem with answers, but we do not accept it as inevitable. Rather, we share the belief that putting our collective resource behind the country's best talent, we can check the rise in healthcare costs while concurrently enhancing patient satisfactions and outcomes. You are that best talent. You are the educators, the activists, the scientists, the implementers who will guide the health system to create that new value." I am in. I am all in. Every bit of me. And I know that you are too. Thank you.